Hello everyone, today we have a discussion about the trypanosomiasis. Compared to the last ET videos, this maybe took a little bit longer because the trypanosomiasis has a little bit different species, like 3 species. We will try to present everyone's each of them accordingly. So stay patient. If you are in hurry, you can watch it like with a fast forward. So, what is trypanosomiasis? Trypanosomiasis, there are many species that are belong to here. Trypanosomiasis just is a genre name. So there are so many species, but among all species, only the 3 of them are infective to human beings, and those are clinically important. The 2 of them, the 3 of them. The first the 3 of them, but initially we are dividing them into 2. The first one is Trypanosomiasis cruzi and Trypanosomiasis brucei. Trypanosomiasis cruzi and Trypanosomiasis brucei. And this Trypanosomiasis brucei also divided into 2. This Trypanosomiasis brucei divided into 2. Trypanosomiasis brucei gambians and Trypanosomiasis brucei rhodesians. So this Trypanosomiasis cruzi usually known as an American Chagas disease or American Trypanosomiasis, or it is called Chagas disease or American Trypanosomiasis. And this Trypanosomiasis gambians and Trypanosomiasis brucei, they both are called African sleeping sickness. Why they call it sleeping sickness, we'll discuss it later in details, but these are the 2 trypanosomiasis that most prominently found in Africa. This Trypanosomiasis gambians usually most common in the West Africa, and this one is most common in the East Africa. So both the Trypanosomiasis cruzi and Trypanosomiasis brucei are their vector-borne disease. They use different vectors for the transmissions. Just to make it clear, this Trypanosomiasis cruzi use the kissing bug or the triatomine bug. And this Trypanosomiasis brucei use Tsetse fly. So these are some of them, their basic difference, and clinically there are so many differences. We will discuss them in details. So it will be nice if we discuss them separately. So I will start from the Chagas disease or the Trypanosomiasis cruzi. They call it American Trypanosomiasis, or they also call it the Chagas disease. The reason they called it Chagas disease because it is initially found by the American scientist called Carlos Chagas. Carlos Chagas is the founder of this disease, and as I mentioned before, it is a etiologic agent. It is a trypanosomiasis, and it is a vector-borne disease, and it is a zoonotic infection, and their vector unit for the transmission of this microorganism is triatomine, or they call it a kissing bud. The reason from the reason that I can explain why they call it the kissing bud is because this this vector or this triatomine usually bite in an area where the carbon dioxide concentration is very high, like in the oral mucosal region where expiratory release the carbon dioxide. So that is the reason why it bites around. So that is why they call it. Usually they bite on the face. So that is what they call it, the kissing bud. So what are the major complications that are clinically raised for the trypanosomiasis? So usually the major and the killer complication of this trypanosomiasis, they are divided into 2 things. They have cardiac complication and GI complication. On the cardiac complication, they basically cause a fibrosis over the myometriums, and they might cause poor cardiac contractions called cardiomyopathy. They can cause arrhythmia, and finally they can also cause sudden cardiac death, maybe their ultimate results. In the GI system, they alter there are nervous plexus, enteric nervous plexus. They alter that, so they can create 2 things, either mega esophagus, or they can cause a megacolon. So we'll discuss them in detail upon the pathophysiology, how these things could happen. So what are the mode of transmission? or how this thing is basically transmitted from person to person. So the mode of transmissions for the Chagas disease is basically two things. The first one is, I repetitively mentioned, it is a zoonotic one, or it is a vector borne. It is vector borne. So in the vector borne, the parasites bite you. So from the saliva, they can release the trimastigotes to your body. So you will develop the clinical condition. So the parasite biting. So the parasite breach, skin breach. It causes skin breaches, or it on the wound. The parasite also bite on that, or on the mucosal surface. On the mucosal surface, the parasite could have the microorganisms that can cause this, could have caused this Chagas disease. The second mode of transmission is, it is called non-vectoral methods. The first one is vector-borne method. This one is non-vector-borne method. So when you say non-vector-borne methods, usually this microorganism can transmit it from person to person with blood transfusion. With blood transfusions, or it can be transmitted from the congenital, from mother to child. It can be transmitted like that. For a patient with organ transplants, or oral injection. Oral injection of these microorganisms can be the mode of transmission. So epidemiologically, it is a global burden, but it is mostly burden for the Latin Americans. It is global burden, but it is mostly burden for the Latin Americans. Usually globally around 6 million new cases found per year. So it is very disease. Thanks to frequency, this Chagas disease usually it's not that much common in our environments, but the Trypanosoma cruzi still, it is a major health problems in the West. So what is the pathogenesis of these microorganisms? Pathogenesis. So when you see the pathogenesis, so either it is vector-borne or non-vector-borne, the microorganisms enter into our body. It will enter to our body. So the trimastigote enter into our body. Once it are entered into our body, it will hunt enucleated cells. So hunt enucleated cells. So RBC like cells, platelets they are free from these infections. So what are the target nucleated cells for these microorganisms? The first one is the cardiac cells. Smooth muscle cells, skeletal muscle cells. So generally muscle cells. The other one is immune systems. They are macrophages. And for some reasons, neurological cells are neurons and glial cells. They are favorable areas for the trypanosomiasis. So once these nucleated cells are, so the microorganisms, what are the trypanosomiasis. Once they are released to the enterocytes, so these trypanosomiasis entered into the nucleated cells, so they will shift from trypanosomiasis to amastigote. So trypanosomiasis to amastigote. So they will change this from the trypanosomiasis to amastigote. So this is a mechanism. So they will do the benefit. So once it's changed into amastigote, it is a reproductive age. This is the infective age. This is the infective stage. But once it reaches to the reproductive age, it will divide themselves and multiply themselves by binary fusion. So they will multiply themselves by binary fusions, and finally they will becomes more abundant, and their size becomes more than the capacity of the cell that it can hold. So finally the cell will rupture, so they will release into the blood streams, and they will infect another nucleated cells, and the cycle will process. So these things can cause two things. Initially it results in innate immune response. So initially it causes inflammatory responses. So initially it can cause innate immune response. What are the innate immune response? Because when the parasites kill the cells, there are intracellular components are released, which are they are immune triggering agents. Yeah. So when there is immune triggering agents are released, so when these immune triggering agents are released, so they will start to call macrophages, dendritic cells, and natural killer cells. So what are these natural macrophages? The innate immune system cell, the macrophages, the natural NK cells, or the natural killer cells, and dendritic cells. These dendritic cells release what? Toll-like receptor. They will release different interleukins. So when they are releasing these inflammatory agents, they will be a damage to the surrounding structures. Keep these things. When there's natural immune systems release a damage to the surrounding structure, that when this process goes for a long times, it will cause it will change this nucleated cells by non-nucleated cells like fibers. So the next step is the response of adaptive immune systems will be started. Okay, so the adaptive immunity that are going to trigger the first one is T helper cells and B cells. So on the T helper cells there are CD4 and CD8 cells. They are basically important. So the first one is T helper mediators. So on the CD4 cells, they basically secrete tumor necrosis factors and interferon gamma. Interferon gamma can be released over the CD8 cells. They can they kill the infected cells. It's the infected cells. CD8 cells basically kill infected cells, and B cells produce antibody to the microorganisms. So after 4 up to 8 weeks, like from 1 month up to 2 months, the parasitemia will start to fall, because there is adaptive immunity response will develop after this long time. So after 4 up to 8 weeks, the parasitemia start to fall for this microorganism. So the next step will be the acute phase. Usually the acute phase takes is to be relieved. Usually is a window period. It is 4 up to 8 weeks. Then after our immunity systems cannot clear out all microorganisms, so they will start to develop a chronic infection phase. So in the chronic infection phase, there are for decades there are these small microorganisms will persist inside the parasitemia, usually in our muscle systems, especially in our smooth muscle systems, in our GI systems, and in our nervous systems. So this can cause a persistent chronic inflammations. This persistent chronic inflammation will be happen. So the final stage will be persistent chronic inflammation. When these persistent chronic inflammations happen, there will be a replacement of these nucleated cells with non-nucleated cells called fibrosis. So when this fibrosis becomes a major issue, when they are exceeding the replacement with destruction, there will be an organ failure. So the final take of my pathologist pathways, this Chagas disease is known for causing a fibrosis of the organ. We can call it either it is on the cardiac cells, on the GI cells, or on the neurologic cells. They can kill by chronic infections, so they can cause a fibrosis. So the final destination will be organ failure. So we will discuss the lethal organ complication of this Chagas disease or Trypanosomiasis. The first one is a cardiac pathogenesis. It is the first one and the most common one, and it is clinically important also, cardiac Trypanosomiasis. I will try to present it briefly. So in the cardiac Trypanosomiasis, it is the most important target. So there will be a persistent inflammations and infection of this myocardial cells or the myocardium. So there will be a development of myocarditis initially. Later on, there will be a formation of a replacement of this myocardial cell with a fibrosis. the same mechanisms happen in here. So what are the final destination possible outcome for this? Of course, the site is totally deep, is very important. For example, if the right ventricles and the right atriums are involved, a SCA node is likely to be involved. So there will be a probability of developing of arrhythmia. And normally, once the SCA nodes, there are AV nodes, and from the AV node there are bundle branch like this. So usually the most common site to be involved is the right ventricles, and the right ventricle, it also contains what is right bundles, right branch bundle branches. So there will be right bundle branch blockage. It is a classic clinical manifestation for the cardiac trypanosomiasis. Another most important clinical finding is there will be a fibrosis left atrium. If the left atrium is involved, this walls becomes thickened. This walls becomes thickened because of the fibrosis. So later on, this becomes a formation of this aneurysm, like it will be dilated like this. So in times, this left atrium, like I will put image here, so it will be dilated like this. It will be dilated like this. So it is a site for the formation of thrombus. It is a site for the thrombation of another stroke events will be happen because of this. Another event will be happen. So what are the clinical conditions that are important happen in the cardiac pathogenesis? The first one is arrhythmia. Arrhythmia will be how the arrhythmia will happen because of the conduction system damage, usually most commonly over the SCA node, AV node, and right bundle branch block. It's only the classic one for it is not this could be maybe benign, but right bundle branch block can be happen. So there are ECG diagnosis. Another one is there may be a cardiomyopathy. The cardiomyopathy is clearer because there are nucleated cells are replaced by non-nucleated cells, so there will be a cardiomyopathy will be happen. So there will be a fibrotic change. The other one is over this the name of what this is called apical aneurysm. There will be a bulging of this left ventricle. It is a very left ventricle. So this apical aneurysm is, it is a site for again for thrombus formation. It is they call it a mural thrombus. It's a thrombus formation. There will be emboli, so stroke event might be happens in this patient. Heart failure also another suspicious thing because the left ventricle is not sending adequate blood to the left ventricle, the left atrium. That is one important thing that you need to take from the microorganism. So doing ECG for the Chagas patients, it is a must things, and doing echocardiography is also critical things for these patients. The other one is what autonomic nervous systems damage or autonomic nervous system trypanosomiasis. Again, the same mechanism still happens. So this nervous system will be replaced with fibrous tissue. So trypanosomiasis usually destroy the ganglions. So the most important site will be affected for the neural system is the autonomic nervous system. As you know, the autonomic nervous system is the one that is control the peripheral nerve, the parasympathetic nervous systems, and the sympathetic nervous systems. So there will be the first one is it can cause it's a dysautonomia. So the autonomic system is not be functioning well. So if the parasympathetic nervous system is damaged, so the patient will not be triggered this parasympathetic or rest in peace nervous system. So the patient will be always in the hurry mode. If the sympathetic nervous system is damaged, again the patient is always resting patient. So that is you need to understand what they do. I will do a video in our neurology in another times, but that is will happen. So the sympathetic nervous systems, for example, if the parasympathetic system on the GI system, for example, on the GI systems, the parasympathetic nervous systems, it can cause the GI secretions, will do that. But in the case of sympathetic system nervous system, the vascular there will be vasoconstriction. These GI hormones might not be released adequately because that is the sympathetic nervous systems. But most importantly, we can notice because of two things. The first one is when you say dysautonomia, the first one is heart rate abnormality is common for these patients. They may be, if the parasympathetic nervous system is happening, the heart rate is always in high. If the sympathetic nervous system is damaged, the patient has bradycardia. The other most important is on a GI motility. If the patient, the parasympathetic nervous system is damaged, it is already sympathetic nervous system, the GI motility is low. But if the parasympathetic nervous system is high, the GI motility is high for these patients. So the autonomic nervous system will be that. So the ganglions are the major sites to be affected. The other one is it is GI trypanosomiasis. In the case of GI trypanosomiasis, again the damage for the site, the target for GI trypanosomiasis is most important. Target is it is the enteric nervous system. Enteric nervous system. As you know, I will put the picture around here. The enteric nervous system is it is a complex nervous systems. It's basically important for controlling of these GI secretions, for the coordinated peristalsis of the GI movements are important, and it contains two plexus. The first one is the Auerbach plexus, or they call it the mesenteric plexus and the mesenteric plexus. The mesenteric plexus. So these are two important. They are very important for the coordinated peristalsis movements. So if these neurons are lost, the result is clear. There will be uncoordination. So they control coordination. If they are lost, there will be uncoordination. Uncoordinated peristalsis will be happen. And the other one is they lose tone. So there will be no coordination. There is no tone. So two things will happen. So when the esophagus system, for example, this one is the esophagus system, this one is the duodenal, the small intestine ball, and there will be a large intestine ball here, like that. And finally, there is a rectum here. So if the coordination, if the peristalsis is not, there is a cardiac sphincter here. Okay, there is a pyloric sphincter here. So if the coordination is poor, for example, if the trypanosomiasis infects the esophagus, and if it infects this enteric nervous system, if the coordination is full, the food is not moving here, so the food just generally stored here. Say one. The other one is if the tone is too, and if the food is stored here, so it will happen. It starts to dilate because the food is not moving and the muscles are relaxed, so it will be dilated throughout in time. It becomes deep like this. It will be dilated like this throughout in time. So that another one is if the enteric nervous system is damaged and the peristalsis full is, the cardiac sphincters will not open. It doesn't let the food to pass into the stomach. So finally this patient could have been presented with a clinical and sign symptoms of megacolons, and they typically looks like achalasia. So the first one and the most important complication is it is megacolon. In the case of megacolon, there is a food storage and there is hypotonicity of the smooth muscles of the cells because the enteric nervous system is damaged. So two things. The first one is no peristalsis. So this one is food store, and the other one is there will be hypotonia. So this can cause relapse. So it can result is this megacolon. So they will not be passed to the lower esophagus. The other one is so how do these patients present? They will present with weight loss. They could have presented with dysphagia, and they could have been presented with regurgitation. Regurgitation will be their clinical presentation. The other one is megacolon is also another clinical importance. So when the same thing, there is no peristalsis, the food is not moving, so the food is staying dormant here, and when there is relaxation, the patient has this relaxed colon. So their clinical symptoms usually the same as HCD. Higgsberg disease. It is a disease where normally a patient with congenital disease where the enteric nervous system is not supplementing the ball for the peristalsis. The same mechanism is also here. The enteric nervous system is damaged by trypanosomiasis, so there is no passage of this. So this was because of these neuron distractions. The patient could have this megacolon. So these are the most common clinical manifestations. So the cardiac clinical arterial complication, autonomic nervous system complication, and the Trypanosomiasis are the most common. So what are the clinical manifestations of this Trypanosomiasis as generally? These are late complication. By the way, cardiac, GI, and ANS are late complication. So the clinical manifestation can be grouped into two. The first one is it is acute phase. Acute phase. The first one is it are acute phase. As I mentioned before, the autonomic nervous system is fully developed from 4 up to 8 weeks. 8 weeks. So up to 8 weeks are at the time where acute phase ends, and after that they will start to develop a chronic phase. A chronic phase will develop after that. So what will happen in the acute phase? Most of the times they are asymptomatic. What the hell? Most of them are asymptomatic. If the patient develops some symptoms from here, maybe early diagnosis is possible, but they are asymptomatic. And but if they become symptomatic, the patient could have developed AFI symptoms. Generally, AFI symptoms could have been like the patient could have these high-grade intermittent fevers. The patient could have present with lymphadenopathy like malaria, and the patient again could have this hepatosplenomegaly because they are infected. The other one is, and the famous one and classic for trypanosomiasis is it is a Roman sign. So what is a Roman sign? It is a Roman sign is there is a painless unilateral eye swelling around the periorbital regions. It is non-pitting edema, and usually it is accompanied with conjunctivitis. And usually again it happens after 1 or 2 weeks of the bite of the microbe. After the bite of 1 up to 2 weeks of this the bite of the kissing bud. That is what will happen. The other most important area is this chagoma. Chagoma is infected site becomes swollen. That is what will happen. So the mortality of this usually the mortality of this Chagas disease usually it ranges around estimated around 5%. If it is appropriately treatment, survivability is high. The other one is it is a chronic phase. In the case of chronic phase, we can group it into two things: indeterminate forms and determinant forms. Usually, there is no symptoms and no asymptomatic, they are indeterminate forms. So, it will be point 1. The first one is indeterminate one. Indeterminate one is they are asymptomatic. Again, the microorganism could be persisted. Their ECG is normal. There is no any bowel problems. This happens around 60 to 70%. Yeah, it is pretty common. Yeah, so most of the times you may carry the microorganisms, but you may feel nothing. In the case of B.2 or in the determinant phase, now here is the problems. It is accompanied around 30 to 40% of the incidence, and it usually happens as a cardiac manifestation, or as a J manifestation, or autonomic nervous system activation, or it could be a reactivation. So it could be cardiac manifestation, it could be J manifestation, it could be autonomic nervous system manifestation, or it could be reactivations. When we say reactivations, especially in a patient with immunocompromised like HIV patients, organ transplant patients, on steroid patients, they could have these reactivations. So how do reactivation patients start to present it? They present as an acute phase. So how do you diagnose this Chagas disease? The diagnosis of the Chagas disease basically depending on the time. So if the patient presented in acute phase, the diagnosis can be simple BF. With blood BF can be the diagnosis. The other one is PCR. This is the diagnostic modality for this one. In the chronic phase, of course, you will do ECG, echocardiography, like that. But for the diagnosis for the Chagas, it is IgG or serology. Serology is specific to this. You can do that either ELISA or IFA tests. You can diagnose them by this way. The other maybe clinically important thing to discuss this, it is a congenital one. So to diagnose congenital, we have to wait for 9 months if the patient is clinically important, because if it is a congenital, in the mother, an antibody can be transmitted from the mother to the baby. So till 9 months, the baby could have these antibodies inside his body. But if they persist for more than 99 months, they are very definitely the diagnostic ones. So we need to wait for the 9 months. Other mode of management is this PCR. PCR. So let me summarize the management and let me present it briefly. So when you see about the management of this Chagas disease, so in the management was, of course, the first one is there is a general management. For example, if the patient presented with this cardiac failure patients, if a patient presented with severe megacolon patient, you need to accordingly act to those complications. So generally they are supportive treatment for these patients, but first I will try to present to think the etiologic treatments. So generally the management principle for we are going to discuss it. We will discuss about the etiologic treatment. Later on we will discuss about treatment of the complication. So how do you manage this etiologic agent, or how do you treat these patients? So the etiologic agents, or the currently well known and established medical medications that can basically kill this Chagas or Trypanosomiasis cruzi, is the first and the famous one, and the first line medications are only we have two approved medications. The first one is benzinidazole. So benzinidazole is the first and the first line medications. So our dose will be, if that it is a child in age is less than 2 years, we are basically use from 5 up to 7.5 milligram per kg per day into divided dose. It is oral medications. It is given PO. It is into divided dose. But if the child is above 12 years, usually we need to provide at least 5 milligrams per kg per day, again into divided doses. For how long do we treat these patients? For 60 days or for 2 months. This should be provided. The other and the second line, if this benzinidazole is not available, the next mode of management is nifurtimox. It is also a second line medication, and it is usually effective for trypanosomiasis cruzi again. So our mode of dose will be from 8 up to 10 milligram per kg per day, around 3 up to 4 divided dose. And our duration will be about from 60 days to 90 days for this nifurtimox. So when do we prefer this benzinidazole? Usually we prefer this nifurtimox usually when benzinidazole is not available. So these are basically heavy medications. So who must be given or who must be treated? Because as I mentioned before, even in the chronic infection, from 60 to 70% are asymptomatic. So who must be treated? So the first one is the patient with acute Chagas disease. The other one is the congenital one. The other one is a patient with age less than 8 years, and the other is woman at age of childbearing. These are, and the last one is reactivation. Especially in the case of HIV patients, steroid patients, they should have to treat it accordingly. The other one is supportive management will be provided. So what are the next one is this treatment of the complication. The next step of management is treatment of the complication. And complication are the one kill the patient. The first one is if it is cardiac complication, and usually patient is present with heart failure, we need to management as heart failure patients. We need to provide AC inhibitors, or we need to provide these ARBs, we need to provide beta blockers, and we need to provide maybe they require corticosteroid. Minimally they make corticosteroids. They maybe provide ACG L2 inhibitors. They may need to control the arrhythmia. With arrhythmic agents may be provided. Usually the arrhythmia is usually controlled with amiodarone may be the agent for this one, especially for ventricular arrhythmia. So these patients for the arrhythmia, usually they may require ICD means implantable cardioverter defibrillator. So they may be usually especially where they are indicated for a patient with sustained ventricular tachycardia, and the patient with high risk of sudden cardiac death may be elements. For a patient with bradycardia, like on the AV blocks, they may be required this ICD. The other one is because of this fibrosis. The other one is GI complication. GI complication. In the case of GI complications, we basically may provide medical treatment. The first one is medically they can be treated for this mega colon, mega esophagus, mega esophagus. For the mega esophagus, the most medically important available mode of treatment is nifedipine. Usually nifedipine is a calcium channel blocker, and it is basically commonly used for antihypertensive agents, but for this case nifedipine can be used. Nifedipine can cause this hypertonic, or it can increase the tone. So before meal, when this patient may be provided this nifedipine, and the tone may be hyper, so the patient cannot have this relaxed esophagus, so it will be forced to go down. The other is isosorbide dinitrate is also another. So they usually do is relax the lower esophagus. They relax lower esophagus, so if there is open way, just directly move to the so they increase the tone, again they relax the lower esophagus. Most importantly one is they relax the lower esophagus, and the other one is this mega colon can be managed with endoscopy. We can do a pneumatic balloon dilation. I will put the picture so that it is an endoscopic management. But surgically there maybe we may do hilar myotomy in the case of severe disease. Surgically hilar myotomy. In the case of severe disease, we can do that. For the case of this mega esophagus, we may, the first one is we need to do the conservative mode of management. We need to promote the patient with high fiber diet. We need to promote for adequate hydration, and we may require to provide these laxatives and enema. Enema may be the mode of management. So for the surgical management, for the symptom, for surgical is done for severe disease. For those who develop this volvulus and those who are this refractory disease, we may do this surgical management. So these are just brief managements for the Trypanosomiasis cruzi or Chagas disease. The other most important discussion will be African Trypanosomiasis. In the case of African Trypanosomiasis, it is caused by the microorganism Trypanosomiasis brucei, and you have two types of African Trypanosomiasis: Trypanosomiasis brucei gambians and Trypanosomiasis brucei rhodesians. And this Trypanosomiasis gambians, it is most common in the West Africa, and it accounts about 95% of the global African Trypanosomiasis, and it is known for its chronic disease. And humans is their only reservoirs. In the case of Trypanosomiasis brucei, they are most commonly in the East Africa and in the South Africa, and they are known for their zoonotic transmissions, and their reservoirs are, so their zoonotic reservoirs are cattle and antelopes. Antelopes are their carriers. So this is a general description. So what are the most important Trypanosomiasis different from the Trypanosomiasis Chagas cruzi is usually most of the Trypanosomiasis that entered into our body, they can be killed. So usually by hook or crook in our bodies, different species of Trypanosomiasis entered into our body. But in the case of Trypanosomiasis brucei, they have this evasion mechanism, so they are not killed because they have the human apolipoprotein is usually the human apolipoprotein L1 is basically kill Trypanosomiasis. Trypanosomiasis. But the African Trypanosomiasis has a mechanism actions, and they have a different way of escaping these mechanisms. They can, some of them they are defensive, some of them like this apolipoprotein one. So in the case of Trypanosomiasis rodents, in the case of Trypanosomiasis brucei they produce what? A glycoprotein. They have produced a glycoprotein wall. A glycoprotein wall. So they are not be killed. They are resistant for apolipoprotein 1. In the case of Trypanosomiasis brucei they produce a serum resistance called SRA. Serum resistance associated protein. They neutralize apoproteins. They neutralize apolipoprotein 1. So this serum resistance associated proteins SRAP, and this one has a glycoprotein that basically used as an capsule. So what is the life cycle? So the life cycles, again, it is a vector-borne disease. It has two hosts, a human host and the Tsetse fly host. So initially the fly will come. So the fly will take from the infected person. Initially she will ingest an infected blood stream. So she will ingest Trypanosomiasis. So this Trypanosomiasis start to enter into the GI of the Tsetse fly. Inside the Tsetse fly, it will multiply itself and it will change it into a procyclic Trypanosomiasis. So it will change it into a procyclic Trypanosomiasis. Once this procyclic Trypanosomiasis, it will migrate into the salivary gland. Migrate into the salivary glands, and it will form what? Epimastigoid inside the salivary gland. So epimastigoid. So procyclic mastigoid, epimastigoid, Trypanosomiasis, and finally in the side salivary glands it will change into metacyclic Trypanosomiasis. So this metacyclic Trypanosomiasis is infective to human. So if you are exposed into this metacyclic Trypanosomiasis, you will immediately develop this African Chagas disease. So what are the next things will happen after this metacyclic Trypanosomiasis infected the human? So in human, this metacyclic Trypanosomiasis will be ingested by Tsetse flies to the human. Tsetse flies to the human. So it will enter into the skin, directly into the skin. It doesn't as I mentioned for the Trypanosomiasis cruzi, it will hunt a nucleated cell. This is extracellular. It is not good inside the cell. So they will start to enter to the skin and they multiply locally. So around when they multiply locally, they will start to develop a trypanosomial cancer. It is a painful inflammatory nodules since in a place where the insect bite. So they will form cancer. It is called trypanosomal cancer. Then it entered from the cancer. It is very infective. It contains many microorganisms. It entered into the blood and the lymphatic system. So once it entered to the blood, when after this metacyclic entered into the Trypanosomiasis entered into the lymphatic systems, they will not invade any cells. They are extracellular and they do not become amastigoid. So there is no amastigoid. So important thing is NBs, they are only extracellular and no amastigoid stage compared to other trypanosomiasis. So they will multiply themselves inside the blood by binary fusion. So they will infect the nervous system. So at this time the patient could have presented AFI symptoms. AFI symptoms may be their initial clinical manifestation. So when another fly ingests these blood streams, so this trypanosomiasis again entered into that blood. Again, these procyclic stages, these epimastigoid stages, and the metacyclic stage will happen. Again, the human becomes infected again. So what is the pathogenesis for this? So immediately after the insect bite, the microorganisms multiply and form a cancer. It is called a trypanosomial cancer. So it is a first lesion. It is a first lesion for the human beings. Then the next one is this hemolymphatic invasion. So if like symptoms like it happens because the macrophages release tumor necrosing factors, interleukins 1 and 6. Interleukin 1 and 6 will be reasons. So the most important thing, or what makes this trypanosomial brucei different from the trypanosomial crucis? Here is the major important thing. As I mentioned before, there is apolipoproteins. Apolipoprotein. This one is a major important thing that can create this trypanosomial disease. But in the case of this, the parathemia produce a surface covered proteins called a variant surface glycoproteins, and it's the immune systems produce antibody for various. So this is a microorganisms. The microorganism is coated by this variant surface glycoproteins. This variant surface glycoprotein is attacked by the immunity cells, the immune cells. They produce an antibody for this immune system, so they will attack here. So now the problem is the microorganisms change these variant surface glycoproteins via enzyme, because they don't have this constant variant surface glycoprotein. So before the white blood cell clear out all the possible microorganisms, the microorganisms change its variant surface glycoproteins. So they need to produce another new antibodies. It takes a lot of times. So because of that, the microorganisms survived for a long period of times, and it can cause a chronic infection. So the parasite change its surface before the immune systems clear all the microorganisms. This variant surface glycoprotein, that is their core that is their core and main pathogenesis. That is the heart of their pathogenesis. That is how they survive inside the human being. So because of this, they can cause a chronic infection, persistent parasitemia, and they have this long disease course. So this is a long disease course will be their clinical manifestation. So they will fool the immune system. They will give the antibody, and the immune system produce antibody for that. The antibody is already changed. That is their main core mechanism of action. So these patients, so usually they are characterized. Another important is they are characterized for their lymphadenopathy. They are characterizing for their lymphadenopathy. So these patients could have these beta cells, plasma cells, and monocells. They can cause the general lymphadenopathy. But the classic lymphadenopathy for this trypanosomiasis process, it is a winter bottom sign. It is a winter bottom sign. If this one is a human being, this one is a neck. So the patient have this lymphadenopathy as a medial next around here. In the middle sternum, if this one is sternocleidomastoid, they will have this neck swelling. So the other sides, so generally these are the stage 1 of the microorganisms. But if they invade inside the cell, they are called stage 2, and their management is totally different. So when they are crossing the blood-brain barriers and enter into our nervous systems, they become called stage 2, or they are invading the nervous system. And in the what happened inside the nervous systems, or stage 2. In the stage 2, the parasitemia invade the white matter. And they cause meningoencephalitis. And the classic area, from the total part of the brain, the classic area where the microorganisms affect is a part of the brain where that controls this circadian rhythms. So affect circadian rhythms. So it is a part where it causes sleep at nights and awakeness at the daytime. So what will happen? So there will be at the daytime, this patient will have sleep, and at night time this patient has insomnia. So this is called this is what is the reason we call it an African sleeping disease, or a sleeping sickness, or African trypanosomiasis. The reason is because it causes sleep disturbance. So So if it is left untreated, in the case of if it after involving if it is left untreated, the patient end up in coma and seizure and encephalopathy, and finally they may develop this aspiration pneumonia, secondary infections, and finally the destination is possibly death. So in order to develop this CNS clinical manifestation, this trypanosomiasis rhodesians, usually it requires from week to months. It is fast progressor. It is fast progressor. But in the case of Trypanosomiasis gambias, it usually requires months to years in order to develop this neurological deficit. The good thing is this trypanosomiasis causes meningoencephalitis, means it causes an inflammatory lesions. There is no fibrosis or there is no any mass effects for this patient. So if they are treating appropriately, it is reversible. The good thing is it is reversible. So how do you diagnose that? So for the Trypanosomiasis brucella gambians, usually they are diagnosed because of two things. The first one is in the endemic area, we have screening techniques called CATs. In the case of cat, it is called card agglutination test for the trypanosomiasis. So the other one is in the case of confirmatory phase. In the case of confirmatory phases, we can do lymph node biopsy, or it can do blood FF, or we can do SSF analysis. But in the case of trypanosomiasis brucella, our management will be BF. BF is the most important management. So when do you say stage 2? The first one is the clinical presentation of this diurnal or circadian rhythms abnormality. But we said stage 2 after we do LP if the trypanosomiasis is identified inside the cell. So one is trypanosomiasis inside the CSF. The second one is if the WBC count is less than 5, it is diagnostic for stage 2. The final one important is how do you manage or how do you treat these patients. So it's depending on two things. The first one is it's depending on the stages, and it's depending on the trypanosomiasis species, because trypanosomiasis gambias and brucella has different rhodesians, and the gambias have different agents. So let's start from the trypanosomiasis brucella gambias. So if it is stage 1 means if it is the dissemination is hematologic and lymphatic systems, our mode of first line management is fexinidazole. First line is fexinidazole. This fexinidazole is provided as for adult 35 kilograms and above. First, we need to provide on day 1 up to 4. We need to provide 1,800 milligrams PO daily, and from day 5 up to day 10, we need to provide 1,200 milligrams PO daily. PO daily must be provided for age above nature. And if because of this, if we are treating appropriately, the curative range is 95%. It is 95%, and they must be provided with food. Fexinidazole is the first line of management. The other stage 1. The other is for stage 1 is this pentamide. In the case of pentamide, usually it is interfere with DNA and RNA synthesis of the microorganisms. It interferes the RNA and DNA. So the dose is 4 milligram per kg per day, either IM or either IV for 7 days. It must be provided. So pentamide must be treated for IV. But what if the patient is trypanosomiasis gambias has stage 2? So if it is stage 2, this means if there is CNS involvement, and if the patient has this mild or non-severe neurological manifestations, again the first line of management is fexinidazole. The problem we call it stage 2 is because we need to choose a medication that can cross the blood-brain barrier. For severe CNS, for severe nervous system deficient, the first and the only the first option is nifrutomax and eflornate combination. They call it NECT. This nifrutomax, and E is for what? Efloronite. So what is their importance? Usually this efloronite, it blocks the ornithine decarboxylase. Block ornithine decarboxylase, and it is used for usually this polymerase chain production. So it is basically important for the growth of the microorganisms and for the DNA synthesis. So it will be blocked by efloronitine. Efloronitine will block it, so the parasite cannot grow. Once it develops, bone cannot be grow, and this nifritomax can damage the DNA. This damage the DNA. It can cause damage the protein. It can cause a cell death. So the dose for is efloronitine is this one. Efloronitine dose will be 200 milligram per kg IV BID for 7 days. So when our normal for nifritomax, again I mentioned it is 5 milligram per kg PO TID 14. So this one is IV. So we need to combine this next. Nifritomax and efloronitine must be combined for the treatment of this management. This for stage 2 Trypanosomiasis brucella gambians. The other one is Trypanosoma brucella rhodesians. How do you manage them? Again, for stage 1, our treatment choices, the first line is it is suramide. Suramide around 4 up to 5 milligram per kg IV at day 1. Then this one is day 1. Then 20 milligram per kg at day 3, at day 10, at day 70, at day 24, and at day 31. This is the management. Suramide must be provided. Initially we provide a low dose, then we need to provide a higher dose. If the patient develops stage 2 is trypanosomiasis, stage 2, if the patient develops stage 2, in the case of trypanosomiasis brucella rhodesians, our management will be, our option is male arisoprol. It is our only one. This medication is basically famous. And no physician wants to give this male arisoprol, because means male arisoprol is basically they can kill the patient too. They can kill the patient. How do they kill the patient? Is because it causes reactive encephalopathy. It can cause reactive encephalopathy. If reactive encephalopathy develops with male arisoprol, it is around 5 to 10% mortality rate for the patient. It has a very high risk of. So the patient may develop this seizure, coma, and brain swelling. So, but if it is important, we need to provide them for the patient with a risk-benefit analysis. So the dose will be 2.2 milligram per kg IV per day, 14 days. Must be provided. The main complication is it's an exam question. Reactive encephalopathy. It can cause a patient seizure, brain swelling, and coma. Coma will be their clinical manifestation. I know it is a very boring topics, but this is all we know about the trypanosomiasis. Thank you.